So, good afternoon, everyone. I'm Dr. Deepu. Today is a very sad day for us because so many people have died in the landslide and the plane crash. So, IHMA expresses its deeply saddened by the sad demise of the.
What your time?
Also, 1 minute, I got a call actually, and also some people have lost their lives in the Rajamala, the landslide. It is a very and it's heavy raining here, and we have very low, less participants today. But as announced, we are continuing this. So before starting, IHMA expresses its heartfelt condolence on the sad demise of people who are lost in their life in the Rajamala and Karipur tragedy. Coming to our session today, as a faculty, we have Dr. Rakhal, Assistant Professor, Department of Repertory, Father Muller Homeopathic Medical College, Mangaluru. He also graduated from Father Muller's in 2010 and also did his post-graduation from GHMCT, Trivandrum. He's a friend of me and a faculty of IHMA CCP program for few years. So I welcome Dr. Rakhal to take the session. Thank you.
Thank you so much, Dr. Deepu, for your heartwarming welcome. I'm so happy to be here. Good afternoon, everyone, at the very outset out there. Though in the, a bad weather, you're coping up with your network, you're stabilizing it, and you're tuning your ears to improve your stature of knowledge. So I appreciate that at the very outset, and good afternoon, all out there. So I'm very happy to be here, a platform raised by IHMA Kerala to share the knowledge and to improve ourselves in with the clinical acumen to compete with the needs of the day, right? So we know that we are living in a scenario where the laboratory investigations are booming up, and they are tuning it, and they are fine tuning it, and we have so much of it. And there are all the chance to get perplexed by looking at varied varieties of investigation which are present in front of us. So I thought, why not we can take a commonest investigation battery, which is usually done in your clinical practice, and very often people reaching your outpatient department will be bringing this particular report. And if you know something about it, it will help you to improve your confidence in facing the patient. You know that now the patients are much more intellectual than us. They are coming to us with all the available data about their sufferings, and they will try to overpower you. If you don't know the basic understanding of the disease with which the patient is approaching you, you will be having a very tough time. So we have to be competent enough to tackle this particular situation. So for today's discussion, we have taken up a very simple diagnostic battery, that is a liver function test. So without wasting much time, let's get into the topic proper. I hope I'm audible. Yeah.
Yeah.
So
okay.
Next. So liver function test. So what is it all about, liver function test? You know that liver function test, as is the generic name which is used over there, is a misnomer. Why? Because we are not analyzing the entire functions of liver, because we know that the largest gland of the body, that is the liver, will be handling a varied synthetic function and detoxifying function, right? And processor, right? It handles almost all the metabolic actions of the body or metabolic works of the body, everything will be taken up by the liver, and liver will be single-handedly handling all these things, right? And it produces all the protein in your body, lipoprotein, the cholesterol will be processed, right? You know that HDL, LDL, VLDL, IDL, all those things, lipids and lipoprotein will be managed by your liver. Whenever you are consuming a lot of food, the liver will be dealing with the carbohydrate metabolism, the protein metabolism, the fat metabolism, the lipid metabolism, right? Whenever you are consuming the drug products, right? You know the drug products, I mean, basically they are not polar. Polar means the substance which are not soluble in the water will be known as polar. So most of the drugs are polar. So until and unless, I mean, non-polar, not polar, non-polar. Non-polar means it is not dissolved in the water. Polar means something which can easily dissolve in the water. So most of the drugs which we are consuming, I'm talking about the conventional treatment, right? So whenever they are consuming a lot of drug, it has to be converted to be polar in order to have it execute its action in the body. So all those, I mean, conversion of the drug and toxin, detoxifying most of the toxin, which are the part and parcel of your food nowadays, and everything will be done by the liver. And also liver, you know, it synthesizes bile, right? And bile will be discharged into your intestine so that the cholesterol and whatever oily things are there, it will be transformed to a digestible form, the micelle. So all these things are varied of function which will be dealt by the liver single-handedly. But liver function test never addresses to all these functions, to be frank enough. And another thing is that the liver function test, it is not at all accurate. It is not at all accurate. The parameters which are used in the liver function test, all those parameters can be varied, or the value can be varied in some other diseases also, other than liver. So it is not very precise. It's not very reliable. But we have a series of parameters which are used in the liver function test. So in the combination of all these things, just like our totality, the combinations of the symptoms, right, make the totality, and it will call a particular drug in your mathematics. Similar like that in the homeopathy, we have similar parameters in the liver function test, and its varying ranges, the combinations of varying ranges makes it meaningful. So what exactly liver function test is? It is not all about measuring all the function executed by the liver, not that, but true test of hepatic synthetic function. So we know that liver is synthesizing so many protein. Almost all the protein except immunoglobulins are produced by the liver. So all those proteins, including clotting factor, will be synthesized by the liver, and we cannot test everything. Only we can look at the main protein which is maximum in your blood, that is albumin, and also your clotting factors, the clotting factors. So they too can be analyzed. They will be analyzed in the liver function test. That is one thing. What is included in the liver function test, I'm telling. And the another thing is that an excretory function, basically bilirubin. We know that bilirubin is a pigment, right? It is just a pigment. It doesn't have any function in the body, right? If it is let free in the blood, it start damaging all the cells which is available in the body. So that will be assessed. So bilirubin is processed and excreted in the with the help of liver. We will discuss what exactly is happening with the bilirubin and how it is excreted. All those things will be addressed. And finally, when the hepatocyte, that is a major parenchymatous component of your liver, when it is injured, the content which is present within the cytoplasm of your hepatocyte, you know that every cell will be having hepatocyte, that content of the cytoplasm of hepatocyte will be oozing into the blood, and that will alarm the injury of your liver. So if in case liver is damaged, the content of the hepatocyte will be discharged, will be discharging into the blood. And when you are assessing, when you are looking at, when you are alarmed by the presence of those enzymes which are normally present within the hepatocyte, when it is becoming the part of the blood, you have to be alarmed because your liver is going to be damaged. So basically these three things will be done in the liver function test, nothing else. So it is basically synthetic function. And another thing is that it is dealing with some excretory function, and we will be looking at certain enzymes discharged out of your liver. So these are the components of the liver function test. So don't expect big, right? This is all about it. And next. So when you are looking at the liver function test, what are the components of it? We just, what's it, categorize them into three groups. We will be assessing the synthetic function of your liver. And second thing is that the excretory function of the liver. The third thing is that the liver cell injury, the enzyme contained within the hepatocyte, whether it is came out or not. This is all about it. And what are the components of this category? The first thing is the total protein. Second thing is the albumin. Globulin is not usually done in the liver function test, which is commonly available in India until and unless it is asked for. And another thing is that bilirubin, total bilirubin. And the most important out of total bilirubin alone won't answer any of your queries, but you have to ask for conjugated bilirubin. That is direct bilirubin. We'll be discussing it. Alkaline phosphatase, an enzyme, ALT, alanine transferases, aspartate transaminases or transferases, and gamma glutamyl transpeptidases, that is GGT. So this is all about the components of the liver function test. Now let's understand how this combination, how these parameters, the combinations of various these parameters makes a sense about the liver injury or undergoing, the pathologies. That's what we are going to discuss. Now, before stepping into the liver function test properly, discussing each parameter, we have to get these parameter has to be categorized in a meaningful group so that we can easily address to it. You can understand it better. How can you do that? First thing is that bilirubin, that is the indirect bilirubin. We will address what is indirect bilirubin. Indirect bilirubin is one category, right? And another thing is that liver enzyme, mainly ALT and AST, that is an alanine transferases and aspartate transferases are one group, right? Another thing is that combination of ALP, that is alkaline phosphatases. The other one is gamma glutamyl transpeptidases, that is GGT. And the another thing is that urobilinogen or direct bilirubin and urobilinogen in your urine. So these are the entire pattern of it. Now let's discuss, let's categorize it for our meaningful understanding. We will try to understand where these components are present, from where these enzymes are coming up, from where these, bilirubin and direct bilirubin, where they are processed, where they are synthesized, and when it is increased, what it is indicating. That we will have a rough idea, then we'll go step by step into each components of it. So you know that this is your beautiful liver, right? This is your beautiful liver. And near liver, you know that liver is supplied by the arteries, right? There are blood supply to it, right? And the liver will be draining so many things. Whatever it is synthesizing will be discharged into the bile duct. And you know that there is another small pouch over here, that is your gallbladder. And gallbladder will be joining your common hepatic duct, and that will become common bile duct. And the common bile duct will be opening into your intestine. Right? So liver is supplied by your hepatic artery and your hepatic artery and your portal vein, right? So the liver is supplied with the blood, and from the blood it will be receiving all those components to be processed, to be synthesized, or the anabolism and the catabolism, or which all components has to be taken from the blood, from the body. It has to be reached to liver to your blood supply. And this big blood vessel is representing the blood supply to the liver, and it is mainly from the hepatic artery and portal system. And when the substance are reaching your liver, when it is reaching the liver, the hepatocyte, the liver is composed of hepatocyte. These are the functional unit of your liver, hepatocytes. So hepatocytes will be processing all those substances which is reaching the liver, right? And if something need to be converted, that will be converted. If something need to be processed, that will be processed. And if something needs to be synthesized, that will be synthesized. And then everything will be put back to your, bile duct. And through the bile duct, it will be reaching to your intestine. And from the intestine, further processing of that thing will be done. So let's understand. We were discussing the components of your liver function test, and let's understand from where these components are coming. From where these components are coming. The first thing we were discussing of bilirubin. You know that bilirubin is a pigment, a yellow pigment. And the yellow pigment have been derived from another organ, that is spleen, right? So in the spleen, spleen is the cemetery of old RBCs. Whenever RBC is getting old and it is worn out and it is not pliable, what will happen is that the RBC will be processed within the liver, within the spleen. This is spleen. So in the spleen, what will happen? The RBC will be processed and RBC will be converted into biliverdin first, right? Biliverdin, and the biliverdin will be finally converted as bilirubin. So RBC is going to spleen. It is getting depleted into biliverdin. Biliverdin is reduced into bilirubin. And the bilirubin is exactly a pigment. So if you leave the pigment like that, what is going to happen is that pigment start injuring every cells in the body. So we have to process the bilirubin properly. So what will happen is that soon after bilirubin is formed, the bilirubin will be bound with a protein. And the protein is known as bilirubin binding protein. It is bilirubin binding protein. Now, bilirubin binding protein will be binding with bilirubin, and this substance will come to the blood. When it will come to the blood, you know that since it is bound to the protein, bilirubin doesn't have a separate existence because it is bound with a protein, bilirubin binding protein. Why we are combining bilirubin binding protein is that the bilirubin should not go and affect the cells unnecessarily. If it is binding with the protein, that will stay within the blood. That will be staying within the blood. Now, this bilirubin, which is bound to a protein, bilirubin binding protein, this combination will be commonly known as indirect bilirubin. Otherwise, it is known as unconjugated bilirubin. Unconjugated bilirubin. Now, you are understanding the first component, the total bilirubin, from where it is coming. The bilirubin is the byproduct of the depletion of the RBC, right? And the bilirubin will be surged into the blood. It will be combining with the protein, becoming unconjugated bilirubin. Now, the unconjugated bilirubin has to be processed because it is a toxin. Essentially, it's a toxin and it is a pigment, right? It has to be processed by the liver. So we are looking at the bilirubin, especially the unconjugated bilirubin, is coming out of liver. It is coming somewhere out of liver and it will be reaching the liver and it will be doing some function. We'll discuss it later. The second thing is that we were discussing that there are hepatocyte. I told you that every liver consists of hepatocyte. Now, within the hepatocyte, what's happening is that there are so many enzymes. Now, which are the enzymes which is present within the hepatocyte? Hepatocyte will be having mainly two kind of enzyme. One enzyme is known as ALT, that is aniline transaminases. The other one is AST, that is aspartate transaminases or transpeptidases. Now, previously it was known as SGPT and AST was known as SGOT. Now we are not conventionally using these particular terminology. They will be called as ALT and AST. Right. Now, AST and ALT are discharged. If it is present within the blood, it is coming out of the hepatocyte. So whenever ALT and AST is increased, what it is talking about is that a pure liver cell injury. So whenever there is a liver cell injury, that ALT and AST will be increased. Why? Because the cell membrane of the hepatocyte, if it is destructed, the enzyme within the hepatocyte will be coming out and it will be spilling into the blood. So AST and LT are the main markers of hepatic injury. Hepatocyte injury, you can say that. Hepatocyte, if it is injured, the ALT and AST are going to be raised. Now, another two components we were talking about are, one is AL, alkaline phosphatase, ALP. Another thing is that GGT, gamma glutamyl transpeptidases. Now, ALP and GGT, from where they are coming, if you are categorizing them, you know that from the liver, there are some pipes which are connected to the liver and through which the secretions of the liver will be reaching the intestine. And it is known as the biliary ductules and right hepatic duct, left hepatic duct. They will be joining to form common hepatic duct. Then they will join to form, they'll join with cystic duct and they will become CBD, that is common bile duct. This is common bile duct. This is common hepatic duct. These are biliary ductules. And biliary ductules are coming from biliary canaliculi. So many small canaliculi, which will be draining each hepatocyte, which are synthesizing bile, and that will be carrying the bile into the intestine. So the precedence is, it will be starting with small tubules, which is known as biliary canaliculi. Biliary canaliculi joins to form biliary ductule joins to form hepatic ducts, then cystic duct joins with hepatic duct to form common bile duct. And finally, they will be opening to the intestine, precisely the second part of the duodenum. This is what's happening. Now, these ductules are lined by cuboidal epithelium. What is that? It will be lined by cuboidal epithelium. And since these are the cell which is lining the biliary tubules or biliary canaliculi, these cells are known as cholangiocytes. What is it? Cholangiocyte. Cholangiocyte. Now, when you are looking at cholangiocyte, when you look inside the cholangiocyte, just like the hepatocyte, they were containing certain enzymes, that is ALT and AST. These cholangiocytes are containing two potential enzymes. They are ALP and GGT. ALP and GGT. So whenever the ALP and GGT is raised within your blood, you have to infer in your mind saying that these enzymes are coming from cholangiocytes, the lining of the biliary ductules and common bile duct. So your common bile duct or the draining system of the liver is in trouble, right? So this is the third category. The fourth category is the entire liver is having synthetic function. We said the entire liver is having synthetic function. What it is doing, it is forming all the protein. Now, when all the proteins are produced, you know that the maximum amount of the protein, the category which is seen among the protein, which is maximum in the blood is albumin. So albumin is the main component of your total protein. So we are going to assess albumin. So albumin, when you are assessing the synthetic function of the liver, right? The second thing is that your liver is producing so many protein. One among them is clotting factor. So clotting factor. So if the clotting factor has to be checked, you have to go for prothrombin time. There is clotting time, bleeding time, all those things. And there is one another timing, that is prothrombin time, the time at which, the seconds at which the prothrombin is converted to thrombin, right? And we will be assessing the prothrombin time. So with the help of prothrombin time and the albumin, you are solely assessing the synthetic function of the liver. So this is all about the category of your liver function test. So in order to go to revise the things once again, you are assessing the bilirubin, which is coming out of the liver from the spleen after destruction of RBC. They will be processed within the liver and will be sent to the intestine. First thing. So it is coming away from liver, out of liver, and it is processed within the liver. So that is the bilirubin which you are assessing first time. The second thing is that the second thing which is assessing the liver function test is the liver enzymes, that is ALT and AST. The ALT and AST are the enzymes which are contained within the hepatocyte. So ALT, AST will talk about the hepatocyte injury, the liver injury proper, or liver parenchymatous injury. And next category, which is present in your liver function test, is ALP and GGT, that is alkaline phosphatase and gamma glutamyl transferases. From where these two things are coming? They are coming from the tubules, which are draining the liver, essentially the bile duct. So they are coming from the cholangiocytes, ALP and GGT. Finally, we are going to assess the albumin and the prothrombin time. They will talk about the synthetic function of the liver. So this is all about the categorization of the liver function test. I hope you're understanding what exactly it is, right? Bilirubin coming out of the liver. AST, ALT talk about hepatocytic injury properly, hepatocytic injury, right? ALP and GGT, alkaline phosphatase and gamma glutamyl transpeptidases, are coming from cholangiocytes, talking about the biliary canaliculi injury. And finally, you are assessing the albumin, total protein, and the clotting factor, that is prothrombin time, talk about the synthetic competency of the liver. If you're assessing the function properly, if you ask me which is the golden standard for assessing the synthetic function of the liver, that is prothrombin time and albumin. Okay, that's all about it. So let's get back into each components of it, how it is deranged and what is its inference. Next. Yeah. So look at this picture. You can see, I mean, the hepatocyte on the left top, and you can see that there are so many enzymes are contained within it, right? And when the cell membrane of the hepatocyte is broken, all those contents which are marked in small dots in different colors will be oozing out, and they are AST and ALT. They will be talking about hepatocytic injury. And another thing which we are seeing, the liver with the biliary ductule, you can see, and the biliary ductule is draining the liver into the intestine. So whenever your biliary ductules, those draining canals, are attacked by any immune complexes or any injury, you are going to see in the liver function test that is ALP is heightened and GGT is heightened, right? Another thing which you are going to see is that the excretion of a pigment, that is the bilirubin. That's all about it. Next. Now let's understand, I mean, bilirubin, right? Bilirubin properly. What is bilirubin? What we can infer from the level of bilirubin? Yes. So can you see in the bilirubin test, I told you that what we are going to look at when you are assessing the bilirubin, I told you that it is a pigment. From where the pigment is coming? You know that from the reticuloendothelial system, when the old RBs are catabolized, right, it will be converted into biliverdin, and biliverdin will be reduced into bilirubin, right? And bilirubin will be combining with a albumin, right? That is bilirubin binding protein, and the combination become the unconjugated bilirubin. What is it? Unconjugated bilirubin. Now here I would like to highlight a beautiful concept. So you know that unconjugated bilirubin, we know that it is a combination of bilirubin and bilirubin binding protein. Why it is combining with the protein? Because it should not go and attack each site, each cell of the body. So bilirubin is a small molecule. It can easily diffuse into different cells and can injure your cells. But when it is combining with the bilirubin binding protein, it becomes macromolecule. It becomes a macromolecule. So this macromolecule cannot be easily diffused into the cells and cannot injure the things. But the thing is that this unconjugated bilirubin can go high, very high, and it can start injuring the brain of the neonate, right? So when the unconjugated bilirubin is going up like anything in the body of the neonate, we know that there is high amount of RBC in the neonates, and there will be so much of hemolysis that will produce a lot of unconjugated bilirubin, right? And that will go and attack your brain. And the condition is known as kernicterus. And this kernicterus, in order to prevent it, you have seen that soon after the birth in our villages and all, the baby will be taken into sunlight, right? Why they're exposing to sunlight? Now the sunlight has been replaced by the phototherapy. Why they are doing it? Why? Because here, you know that we already told that unconjugated bilirubin cannot diffuse into the cell. Then why it is attacking the brain? Why? Because the blood-brain barrier, the blood-brain barrier of your neonate is not well developed. So this particular complex can easily diffuse into the brain and attack the brain. So what we can do, and another thing is that the unconjugated bilirubin is not water soluble. It is non-polar. It is non-polar. So this non-polar substance has to be converted into polar. It has to be made dissolvable in the water. So how we are going to do? So when you are exposing the kid, the skin of the kid to the sunlight, the content of the sunlight will do photooxidation, and they will convert this unconjugated bilirubin into dissolvable water-soluble particles. So for that same purpose, we are doing the phototherapy. That is purpose of doing phototherapy in case of neonate to prevent the kernicterus. I hope it is clear. Now, whenever hemolysis, when you are reading, your liver function test, and the liver function test, if unconjugated bilirubin is increased like anything, the first inference should be, it could be hemolysis. It could be hemolysis, means excessive RBC is destroyed and it is put into the blood. The bilirubin is heaped in the blood, and it will be shown as unconjugated bilirubin or indirect bilirubin. We won't write it as unconjugated bilirubin. It will be written as indirect bilirubin that will be increasing within the blood. Right. Now, this particular unconjugated bilirubin, yeah, it is there in the picture. You can go to the slide. So in the slide, you can see the unconjugated bilirubin is coming into the liver. Liver will be uptaking this particular particle with the help of a particular receptor, right? And the receptor will be accepting it, that organic anion transport protein. And this free bilirubin will be taken inside the liver. And soon after entering inside the liver will be converting this unconjugated bilirubin into conjugated bilirubin. So what is the main difference between the conjugation and unconjugated bilirubin? Unconjugated bilirubin is a water insoluble particle, but conjugated bilirubin is water soluble particle. So I told you that most of it happens with the drugs also. When you're taking the drug has to be converted into polar. It is normally non-polar. This conversion, converting non-polar into polar, is done mainly by the liver. So here also, the unconjugated bilirubin, which is not water soluble, because pigment has to be expelled out of the body because it is toxic. So since it is not dissolvable in the water, you cannot expel it out. So how we are going to do that? Liver is going to do that by converting or making into water soluble substance, that is conjugated bilirubin, by combining with UDP glucuronyl transferase. And there will be unconjugated bilirubin is produced. So there are out of bilirubin, there are two things. One is conjugated bilirubin, other one is unconjugated bilirubin. The unconjugated bilirubin is water insoluble and conjugated bilirubin is water soluble. Now this particular substance, that is conjugated bilirubin, will be excreted into the biliary ductules, canaliculi, and that will flow through the common hepatic duct. It will reach, it will be the part of the bile. Bile is something different. I'll talk about it. So as a part of the bile, the bilirubin comes into the conjugated bilirubin, comes down to the intestine. In the intestine, it will be converted into urobilinogen. And the urobilinogen will be further reduced into urobilin and stercobilin. So these are unimportant things. We don't have to look at it. So the first thing we have to see is this, that whenever you are discussing about one is indirect bilirubin, and indirect bilirubin within the liver, it will become direct bilirubin.
Suraj, can you please zoom the screen?
Yeah.
Suraj, please zoom the screen. I think it is very...
Okay. So direct bilirubin will be secreted into the intestine and it will be converted into urobilin or urobilinogen. Right. So here the conjugation is taking place within the liver. Conjugation is taking place within the liver. Right. So if when you are looking at the bilirubin, total bilirubin should be come within 1.4 mg per deciliter. Right. It should not go above 1.4, right, or 1.2 you can say, right. And out of total bilirubin, you have to ask for whether it is direct bilirubinemia, direct bilirubin is increased, or indirect is increased. Direct is increased or indirect is increased. So direct bilirubin, when it is increased, it talks about the hepatic injury or some problem with the conjugation within the. If it is indirect bilirubin, it is not converting into direct bilirubin. So there is some problem in the liver in conjugation, in converting into polar. But if it is direct bilirubinemia, there is no problem in, outside the liver, and within the liver also there is no problem. But thing is that it is either it is not flowing down properly into the, intestine, or it is not secreted properly into the biliary ductules. So direct bilirubin and indirect bilirubin, these are the two components of the total bilirubin, right? Indirect bilirubin, if it is increased, you don't have to think about the liver problem, right? But direct bilirubin is always talk about, it is synthesizing, but it is not reaching into the, intestine. If it is not reaching into the intestine, urobilinogen is not going to be produced within the body. And urobilinogen, when it is, synthesized within the intestine, it has to be excreted to the kidney. So when you check out the urine properly every time, the urine has to contain urobilinogen. But in case of, if it is not secreting the direct bilirubin, if it is not reaching to the intestine, what will happen is that the urobilinogen won't be present within the urine. That is one thing, right? So these are the two things you have to keep in the mind. Now, yeah. So this is all about it. RBC is broken down. It is coming to the liver. Liver, it is getting conjugated, and it is sent to the gut. Gut, it is converted into urobilinogen, right? It is excreted to the feces and excreted to the urine. So if the direct bilirubin is so much high, right? And if it is not, urobilinogen is not present in the urine, you can tell that it is direct hyper bilirubinemia, right? It is talking about the bilirubin is not properly getting secreted into the hepatocyte, into the biliary canaliculi, right? So this is all about bilirubin. Next. So bilirubin, I told you that there are two types of bilirubin. One is direct bilirubin, otherwise indirect bilirubin, right? So indirect bilirubin is unconjugated bilirubin, which is not soluble in the water. Direct bilirubin is soluble in the water because it is converted into bilirubin diglucuronide by conjugating with a UDP glucuronyl transferase. So that is direct bilirubin. Okay. So and another beautiful thing is that, another thing is that, see, when the direct bilirubin is increased within the blood, I'll tell you that direct bilirubin is produced over here, direct bilirubin, and direct bilirubin is present. It is produced and it is excreted into the biliary canaliculi. But if there are some blockage in secreting the, direct bilirubin into the intestine, you know that the direct bilirubin along with the bile will be contained within the, biliary canaliculi. And this particular state, this condition is known as cholestasis. Cholestasis. cholestasis, right? In cholestasis, what is happening is that, you know that bile is a secretion which contains three things. One is bilirubin, right? One is bilirubin. Another thing is that cholesterol, and bile salts, bile salts. So if there is a block within the canaliculi, the bile which is containing direct bilirubin is not flowing down, but it is contained within the biliary canaliculi, and there is a distension of the intrahepatic biliary canaliculi. So when it is contained within the intrahepatic canaliculi, it will overflow or spill into the nearby blood vessels. So all these things will be present within the blood. What are they? Bile, direct bilirubin will be increased within the blood, and there will be bile salts will be increased within the blood. Right. And another thing is that since this bile is not reaching the intestine, your fat containing food which you are consuming is not digested within the intestine, and it will be expelled as it is clay colored stool. It is called steatorrhea. Right? Fatty stool or chalky stool. Right? So what we are talking exactly is this: bilirubin. There are two components. One is direct and indirect. If it is indirect, the problem is probably outside the liver, vicinity of the liver. If it is direct bilirubin, it might be because of cholestasis, right? So since it is overspilling into the blood, the direct bilirubin is soluble within the water. So direct bilirubin, since it is soluble within the water, the direct bilirubin start appearing in the urine as dark colored urine. So in case of cholestasis or obstructive jaundice, we call it as obstructive jaundice. In case of obstructive jaundice, you will be having clay colored stool. Another thing is that you'll be having dark colored urine. Another thing is that urobilin will be missing within the urine, right? And the bile salts, since it is going into the blood, you will be start having severe itching without eruption. We have a rubric called itching without eruption, right? And it is aptly fitting into the cholestatic jaundice or obstructive jaundice. And also you'll be having low pulse because the bile salts go and switch off your SA node. So this is all about the bilirubin, which we are talking about. That's the first component of your liver function. Next. Now, when you are looking at the homeopathy perspective, how this particular understanding of direct and indirect helps you in prescribing the remedy, right? So whenever you're having jaundice, you know that we have a rubric called skin discoloration yellow, and this is taken from Synthesis Schroyens. And these are the main remedies which are indicated for yellow, that is jaundice of your body. Now, the jaundice alone won't help you to prescribe this remedy. But look at the sub-rubrics of that particular rubric, that is skin yellow, discoloration yellow, that is jaundice. You will be having sub-rubric as accompanied by catarrh, accompanied by gastroduodenal, catarrh, accompanied with external dropsy. So all these characteristic features will help you to differentiate the remedy between the jaundice. So this is generally for the jaundice, when you are seeing that total bilirubin is so much increased. Now, when you look at the different category of it, that is indirect and direct, then you can start classifying next. I told you that whenever you are having direct hyperbilirubinemia, you know, there is bilirubin is increased, but it is, when you're looking at it, direct bilirubin is too much. Then it is talk about obstructive jaundice, that is the bile is not reaching into the intestine and your fatty food is not digested properly. You will be having a white stool, you will be having a dark browny or dark colored urine, your pulse will be slow, and you'll be having, you will be having severe itching in the body without eruption, right? And also the main cause for this particular obstructive jaundice is gallstone, most often. Most oftenly, it is gallstone. So you have to think about gallstone in it. So when you are seeing direct hyperbilirubinemia in your LFT, the rubric which you have to take is that stool white, urine color dark brown or urine color dark, general pulse low, and abdomen gallstones. Why I have included abdomen gallstone is that gallstone, if it is not detected, there is no pain. But when you are seeing the direct hyperbilirubinemia, the most commonly the cause is the gallstone. So though it is not manifested as a symptom, but you can directly, since you have the pathological knowledge you can include abdomen gallstones. So when you're repertorizing, the main remedy which is coming up is chelidonium, lactasis, spodophyllum, sepia, digitalis, aconitum, belladonna, and calcarea. So these are the remedy which are indicated for your direct hyperbilirubinemia. So I'm talking about looking at the LFT, how you can derive the what is a repertorial rubric, and you can understand what is the pathology. So this is all about, I mean, what is your bilirubin. Another thing is that when you're treating LFT, which is altered, and symptoms are subsided, the white stool has been subsided, there is no, the urine has been cleared, there is no itching without eruption, the abdomen, there is no pain in the abdomen, there is no sensitivity of the liver, nothing is there, everything has been recovered. But when you're testing the LFT, still the bilirubin is high. It has not resolved back. You know what is the mystery behind it? There is something called delta bilirubin. 1 second, I'm going to finish it. There is something called delta bilirubin. Delta bilirubin. You know what is delta bilirubin? Conjugated bilirubin plus protein. The combination of protein and conjugated bilirubin is known as delta bilirubin. Now, delta bilirubin is having a long half-life, say 1 to 2 weeks. So when you talk about the delta bilirubin, it takes weeks together to resolve back or to come to normal. So what is the key point to be remembered is that when you are treating the jaundice, all the symptomatology of the patient is very much better, and total bilirubin is increased. And ask for whether it is direct or indirect. Ask for the direct bilirubin. So when your direct bilirubin seems to be high, it is because of the delta bilirubin, which is having a long half-life. So the patient is healthy, the patient has come to normal, but the delta bilirubin is playing a tricky way that it is mesmerizing you, saying that the liver function test is altered. But actually, you don't have to be worried. Why? Because the delta bilirubin, it will take 1 to 2 weeks to resolve back. So this is all about the bilirubin. Next. So this is now the next thing which we have to look at, the liver enzyme. I told you that the liver enzymes are mainly the hepatocytic produced HSR, ALT and AST, right? Next. So ALT and AST, they are produced by the hepatocyte. So when the hepatocyte is intact, you won't see the ALT and AST in the blood. That is wrong. Why? Because AST is produced by some other tissues also. For example, your bone will be producing AST, your placenta will be producing AST, your brain will be producing AST, your muscle will be producing AST. So AST is not very peculiar about the liver. AST never alone singly talk about the liver injury. Though it is, AST is produced by liver as well as some other tissue. But when you look at ALT, ALT is more precise. It is also produced by some other cells. But thing is that ALT is having a precise, indication. So ALT, if it is raised, then it will talk about, along with the AST raised, then it will talk about liver injury. That is hepatocytic injury. I hope it is understanding. We are talking about the main component of your LFT, that is AST and ALT. What is AST and ALT? They are the liver enzyme. Where they are contained? Within the hepatocyte. So when the hepatocyte is broken down, the enzyme contained within it will ooze out and it will start spilling your blood, and blood, when you're testing, it will be high. Which is more precise among AST and ALT, which is more precise about liver injury, that is ALT. Why not AST? Because AST is produced like some other tissues. Now, how to read this particular ALT and AST? When you look at this particular picture, you can see that the normal value, that is ALT, the normal value upper limit is 45 international unit, and aspartate transmembrane is 35 international unit, right? The combination will speak about so many things. Now, ALT and AST, next thing. This is a simple, flow chart. With the help of that particular thing, you can think about, what is the disease? You know, ALT and AST, if it is increased by 3 times, 3 times means, when you talk about ALT, if the level is 225 and above, then it is alarming, right? If it is raised within the threefold, if it is not crossing the value 225, then it is not very significant. Similarly, AST, if it is increased by threefold and within the limit of threefold, that is 225, it is reading, it is not very significant. But if it is going above, threefold, if it is going to 15-fold, for example, if it is coming to 675, the ALT is 675 and AST is around 500 plus, then it is alarming for us. What is alarming? There is a severe acute injury which is going on. There is a severe acute injury going on. So what we are talking about ALT and AST is that ALT and AST is significant if it is increased by threefold. First point, right? If it is increased by threefold, you have to look for the albumin. If the albumin is normal, then it is talking about acute liver injury. Threefold increase of the AST and ALT and albumin is low, then it is talking about the chronic liver injury, right? This is all about it. This is chronic liver injury. Another thing, there is a tricky thing. I told you that the most valuable factor among ALT and AST is ALT. Why? Because it is more liver specific. But another point is that there is some area where AST will be more and ALT will be increased, but it is not apt to, ALT. So it is typically seen in alcoholic liver disease and cirrhosis. It is typically seen in alcoholic liver disease and cirrhosis. In alcoholic liver disease and cirrhosis, what will happen is that AST will be more and the ALT will be comparatively less. And we say that AST-ALT ratio. We'll say that AST-ALT ratio. So AST-ALT ratio should not be more than 1. It should not be more than 1 in whatever increased case. But if the AST-ALT ratio means AST, the level of AST divided by level of ALT, if it is more than 2, means AST is too much high and the ALT is relatively less, then it will talk about alcoholic liver injury. Alcoholic liver injury, right? And cirrhosis. And cirrhosis, okay. Now this is next. Yeah, another thing this is all about ALT and AST, right? What we understood is that it should be more than threefold of it, then it is positive. And it is talk about acute injury if there is albumin is not altered, right? And ALT and AST is altered, it is increased more than threefold, and albumin is altered, it is talk about chronic liver injury. And if AST is more and ALT is less, both are increased, then it will talk about alcoholic liver injury or cirrhosis. This is all about ALT and AST. Now we are going to the canalicular markers. Which are the canalicular markers? One is GGT and the other one is alkaline phosphatase. And alkaline phosphatase and GGT, they are secreted by the cholangiocytes. And when it is increased by threefold, then it is positive. You don't have to look at the GGT, you have to look at the alkaline phosphatase. If it is increased by threefold, then it is talk about the canalicular injury. Which are the canalicular injury? You know that primary biliary cirrhosis, primary sclerosing cholangitis, there is intrahepatic cholestasis. These are the intrahepatic canalicular injury. So when there are canalicular injury or there are bile duct obstruction, there is obstructive jaundice, there is cholestasis, then there will be direct hyperbilirubinemia. ALP will be increased along with GGT will be increased. If ALP is alone increased, it is not significant of the canalicular injury. We understood why. Why? Because within the cholangiocyte, both the enzymes are contained. So if it is injured, both has to come out. Unilateral single ALP, alkaline phosphatase increase, doesn't talk about the liver injury, except some, metastasis, which is going to the liver. But otherwise, ALP, if it is increased, and if you have to suspect about liver injury, along with ALT, what has to increase? Your GGT should be increased. So ALP and GGT, if it is increased together, it talks about canalicular injury. So ALP and AST talk about hepatocyte injury. With albumin reduction, then it is chronic. Without albumin alteration, it is acute injury. AST more than ALT, then it is talk about alcoholic liver diseases and cirrhosis. GGT and ALP is together increase, cholestasis and canalicular injury. I hope it is clear. So we are talking about the canalicular injury for primary sclerosing cholangitis or primary biliary cirrhosis is an autoimmune disease mostly seen in men. Right. Okay. So these are the things which we have to see. Now, next. Now, whenever you're looking at, AST and ALT is increased and ALP and GGT is increased, what is the rubric has to be taken? There is no direct, a rubric for that. You have to take inflammation, abdomen inflammation, liver. Inflammation, liver. And if along with the AST and ALT, if the albumin is reduced, the synthetic function has gone down, then you have to consider that it is a chronic liver injury. So what is the rubric you have to take? Liver, inflammation, liver, chronic. And the chronic you can see natrum, sulfur, and lycopodium are the 3-mark medicines. So I hope it is clear. So when there is an acute inflammation, go for liver hepatitis, acute. And if it is chronic, that albumin is reduced along with AST and ALT, then you have to consider hepatitis, inflammation, liver, chronic. Okay, next. Now we are talking about the ALP and GGT. I told you that these are the canalicular markers. Again, I'm telling it is canalicular markers. When there are canalicular markers are increased, ALP along with GGT, and there is one more, marker for canalicular injury, that is 5-nucleotidases. That is not normally the part of liver function test in India. You have to ask separately for that. But ALP and GGT together, if it is increased more than 3-fold, then it talk about cholestasis. What is cholestasis? There is an obstruction in the biliary tubule and the bile is stagnated over there and it is spilling into the blood. So there will be direct hyperbilirubinemia and there is a dark urine and there is a clay colored stool. That we understood. Now in the cholestasis, it can be intrahepatic and extrahepatic. In the intrahepatic, it can be because of small chronic inflammation like primary sclerosing cholangitis or primary biliary cirrhosis, right? Or strictures. If extrahepatic, the obstruction has to be outside the liver, in the bile duct or common bile duct. It is commonly caused by the gallstones, right? In case of extrahepatic cholestasis, the GGT will be too much high. The GGT will be too much high in case of extrahepatic, comparing with the intrahepatic cholestasis. So in the both cholestasis, intra and extrahepatic, ALP and GGT will be increased and there cannot be a rise in AST and ALT. But ALP and GGT is increased. In case of extrahepatic, GGT will be too much high comparing to ALP or comparing with intrahepatic. Now, in this case, how will you select a rubric? Now, in cases of, ALP and GGT is increased and GGT is too much high, you have to suspect extrahepatic cholestasis. So the most commonest, cause is gallstone. So the rubric you have to address in that case of LFT is gallstone. GGT and LP is raised and GGT is too much high, talking about extrahepatic obstruction, right? Next. Or it can be due to pancreatic head, carcinoma of head of the pancreas, that you can take like that. Another thing is, before that. And another thing you can consider a rubric is colic gallstone. Colic is always produced by constriction of the tubules, right? So gallstone, when it is impacting your bile, there can be severe colic pain. So when there is GGT and LP is increased, you can consider this particular rubric, that is colic gallstone. Next. Now, another thing we told that there is an intrahepatic cholangitis, right? There is a fibrosis and thinning and stricture of the bile ductules which is present within the liver. So how will you convert it into rubric? So you have to be little, tricky over there. So you have to consider inflammation liver. The remedy should act on the liver and producing the inflammation. And the remedy should be capable of producing fibrosis. So is there a rubric for fibrosis? You have to go to skin, keloid. And those remedies which are capable of producing keloids, they will be, if they're having the action on the liver, certainly they have to have the fibrosis in the intrahepatic areas. So these are the remedies: nitric acid, silesia, arsenicum, graphitis, nexomica, sulfur, calcarea, including there is a beautiful remedy called thiocinaminum, right? Thiocinamin is specifically for removing the fibrotic or strictures, right? So you may give it in case of, intrahepatic cholestasis. How will you understand intrahepatic cholestasis? ALP will be raised and GGT will be raised and both will be together raised more than 3-fold, right? And all these reading can come to, more than 1,000. When it is more than 15x, 15-fold, if it is too much high, all these markers, you have to refer the patient. Why? Because it is fulminant hepatitis. The patient can go for encephalopathy. You know what is encephalopathy? We normally say that it is, liver failure. What is liver failure? I told you that all the acute liver disturbances along with encephalopathy is known as liver failure. What is that? Liver symptom and abnormal liver function test along with encephalopathy. The patient altered delirium, cannot talk, cannot understand, right? So all these things comes in encephalopathy. What is the reason for the encephalopathy? Because of the ammonia. You know that ammonia, which is produced within the body, is handled by liver and will be converted to the urea, and it will be expelled out of the body through the feces and urine. Right. If the liver is not functioning properly, the hepatocyte is injured, they cannot handle ammonia. Ammonia will boom up in the blood, and brain will take up converting the ammonia. And the ammonia will be converted into glutamine, and they will stay in the brain tissues, especially astrocyte, and there is metabolic encephalopathy. So when we say that chronic liver failure or acute liver failure, the fulminant state, the intensified liver injury, acutely or chronically, along with encephalopathy, is known as liver failure. What is the reason for that? The body is unable to handle ammonia, and the ammonia start injuring your brain. Right? So what is the marker over there? Ammonia. So along with these markers, ammonia is more in the blood, then you can say that it is acute liver failure or chronic liver failure. So this is all about, this is how we frame the rubric in intrahepatic cholestasis. Next, albumin. I told you that albumin is a main protein, which is the part of the blood, which is maintained in the oncotic pressure. And if it is lowering down, you will be having edema and all those things. And if albumin is reduced, we have so many cases, right? Gastrosis, cirrhosis, and nephrosis. In case of nephrotic kidney, if it is injured, if you're having glomerulopathy, what will happen? A lot of albumin will be depleted through the urine, and you will be having albuminuria, and you will be having anasarca. Another thing is that gastropathy. If you are having protein losing enteropathy, if your intestine is not absorbing the protein properly, what will happen? There will be hypoalbuminemia, and you will be having edema and also cirrhosis. What is the cause for this? Why cirrhosis is producing albuminemia, hypoalbuminemia? Why? Because if the liver cells are injured, it cannot synthesize the protein, especially albumin. So total protein and albumin will be reduced. What is that? Total protein and albumin will be reduced. So when there is total protein and albumin is reduced, it talks about chronic liver injury. So along with the ALT and AST is raised and albumin is reduced, total protein is reduced. What is the inference? It is a chronic synthetic dysfunction of the liver. Right. So that is a significance of the albumin. Now we are going for the clotting factor. Similarly, so these are the normal value of the, total protein and albumin. We don't look at globulin. Why? Because globulins are produced by plasma cells, the WBCs. Activated WBCs are known as plasma cells. The plasma cell will be producing immunoglobulins. So we don't count it in the synthetic function of the liver. We mainly look at the total protein and albumin. Now, the next thing is the prothrombin time. You know what is prothrombin time? Normally it is between 10 to 15 seconds. You have to ask for the prothrombin time. What is prothrombin time? If the clotting factors are not synthesized properly by the liver, what will happen is that you will be having a bleeding tendency. And that is inferred with the help of prothrombin time. Along the liver function, liver cell failure, it will not only fail to produce albumin, but also it will also fail in producing what? Clotting factors, right? So clotting factors, if it is not synthesized properly, how will you assess it? Ask for a prothrombin time. And nowadays in the prothrombin time, we ask for INR. You know what is the INR? It is international normalized ratio. So if somebody is taking the blood thinners, you know that somebody, if people go with a myocardial infarction, if they're having coronary artery diseases, then they go to the conventional treatment, they will be given with aspirin 75, 125 to be taken in the afternoon. And they regularly check for INR. You know what is that INR? That is international normalized ratio. That is a value in order to streamline all the, different lab will be having different value. To normalize it, they have come up with international normalized ratio. So this talk about how is there any bleeding tendency with the blood. So if there is a bleeding tendency which has developed and which is indicated by altered prothrombin time, that is normally 10 to 15 seconds, and international normalized ratio, that is 1 to 2, right? If it is more than that, then it is talk about the liver has failed to synthesize protein as well as the clotting factor. Next. You know, this is about the INR. If it is more than 5, there is a high risk for, what is the bleeding, right? Talks about, your hepatic failure. Next. This is the cascade which is normally played in the clotting. You know that there is a intrinsic pathway, there is an extrinsic pathway. And in the extrinsic pathway, we have so many clotting factor, which is playing one after another the role. That is factor 7, factor 9, factor 8, factor 13 and 12, all those things. All these factors 1, 2, 7, 9, 10, 11 are produced by the liver. So the first clotting factor to be extinguished or stopped synthesized in a disease hepatic synthetic dysfunction is the factor 7. The factor 7 is the first one to go out of the synthesis failure, right? If the liver failed to synthesize the clotting factor, the first one to go out of the range is, or the reduce in the level is that factor 7. Okay, so when these factors are going, what will happen is that the prothrombin won't be converted into thrombin. That will convert fibrinogen to fibrin. That is a permanent clot. So the prothrombin time will be increased. So there is a risk for bleeding. So here, what all rubric you will consider? All those bleeding tendency. The gum bleeds, the injuries, the slightest injury. Bleed profusely. All these rubric can be considered in that. Next. Another thing is that the last stage of the liver, what is that? That is cirrhosis or cancer. So if it is left untreated, all these liver function tests, if you are not assessing properly, and if it has gone to a serious liver failure, cirrhosis of liver, cancer of liver, these are the remedy which is indicated. Cancer liver, these are the medicine, and cirrhosis of the liver, there are direct rubric, you can refer that. Now finally, or discussing all these things, that is bilirubin, the ALT-AST, the liver hepatocyte enzyme, and the canalicular cell enzyme, that is DGT and the ALP, and finally the synthetic function indicator, albumin, and prothrombin time clotting factor. How to read all together, how we can understand all the combination of it. You know, you don't have to worry about it. There are only 5 to 6 commonly seen patterns. If you understand that, you know everything. We are going for that next. So make a note of it. This is very, very important. If you know this, you know everything about the LFT. You know, when there is a hepatocellular failure, if the hepatocytes are in the problem, what will happen is that AST, ALT will be so much high, right? And ALT is more than AST, then it is hepatocellular, where alkaline phosphatase can be mildly or moderately enlarged, only mildly enlarged, or it can be normal. Bilirubin can be normal or slightly raised. You cannot say. Albumin will be normal, and prothrombin time will be normal or slightly reduced or increased. So this is all about the hepatocellular injury, that is hepatitis. The cells are in the problem. When it is cholestatic, what is cholestatic? When the canaliculi is injured, how to infer? Canaliculi is injured, the canalicular markers are alkaline phosphatase and GGT. That will be increased so much. But AST and ALT can be normal, slightly raised. But bilirubin will be highly raised. And which bilirubin? The highest bilirubin, that is direct bilirubin, because the indirect bilirubin has been converted to direct bilirubin, but it is not flowing into the intestine because there is a block, there is a cholestasis. So there is a hyperbilirubinemia, mainly direct hyperbilirubinemia, and there is clay-colored stool, and there is dark urine. Along with that, alkaline phosphatase and GGT is tremendously increased, more than 3-fold. And albumin and prothrombin will be quite normal because there is no hepatocellular injury, only canaliculi is injured. For example, primary biliary cirrhosis and primary sclerosing cholangitis. These are the commonest cause for that. Isolated hyperbilirubinemia. Only bilirubin is raised, nothing else. There is no other indicator which is raised. So you know that all other parameters are normal, but there is a hyperbilirubinemia. If that is isolated hyperbilirubinemia, you have to check whether it is indirect or direct. If it is indirect, then you have to infer that there is some problem with conversion of indirect into direct. So there is a conjugation is not happening. So there are some, inherited conjugation defect where there is UDP glucuronide transferase. There is an enzyme which is converting the unconjugated bilirubin to conjugated bilirubin. If that enzyme is default lacking, there are some condition called Crigler-Najjar syndrome. There is something called Gilbert syndrome. These are the syndrome which can cause reduction of the enzyme ligandin, and there is no conjugation. So what is happening here? There is no liver injury, but there is a hyperbilirubinemia, and it is unconjugated. If it is conjugated hyperbilirubinemia and there is no hepatocellular injury, there is no canalicular markers, the albumin is normal, the prothrombin time is normal, then you have to understand that conjugation is happening, but there is direct hyperbilirubinemia. Why? Hyperbilirubin, the conjugated bilirubin is produced, but it is not getting secreted into the canaliculi. Then there are some protein malformations, right? Protein dysfunction, which is sending or which is taking the conjugated bilirubin from the hepatocyte into the canalicular site. That particular syndrome is known as Rota's syndrome and Dubin-Johnson syndrome. So what we are talking about, isolated hyperbilirubinemia. If it is unconjugated is more, then you are talking about Crigler-Najjar and Gilbert's. If it is conjugated hyperbilirubinemia, there is no other markers increased, only direct hyperbilirubinemia. Then you have to think about Rota's syndrome and Dubin-Johnson syndrome. So that's all about isolated hyperbilirubinemia. And isolated synthetic dysfunction. What will you talk about it? And you have to see that only there are albumin is going down and prothrombin time is going down, and all other liver markers are normal. Then you have to see that it is not because of the liver, because hepatocells are functioning properly, there is no hepatocellular injury, but still albumin is reduced, then prothrombin time is reduced. Then you have to think about some other cause for reduced albumin. What are they? Could be nephrosis, could be gastrosis, could be clotting factor defects, Christmas disease, right? Or hemophilia can be the cause. So don't burden liver with a bad inference. Okay, next commonly seen thing is that benign recurrent intrahepatic cholestasis and progressive family intracholestasis. These are very benign syndrome where there are always some bilirubin is increased, but there is no synthetic dysfunction. But what will happen is that since there is a recurrent intrahepatic cholestasis, the canalicular markers will be slightly above, and you don't have to treat it. Why? Because whenever there is a stress, there will be jaundice. But if they are perfectly normal, perfect with the routine, there won't be any problem at all. But there will be repeated history of jaundice, more than 10, more than 15. Whenever they are stressed, there is a jaundice. Then you have to think about these two conditions. They are benign recurrent intrahepatic cholestasis. Another thing is progressive familial intracholestasis, where the ALP and GGT is increased, but most often here is GGT will be normal, only ALP is increased, right? Only ALP is increased. We know that when there are canalicular injury, there are ALP and GGT will be increased together. But here, only ALP will be increased, but GGT will be normal. And along with that, how will you say that ALP is increased? How you can say that it is because of the canalicular injury? Then you have to look at the bilirubin, because bilirubin will be increased over there, especially direct hyperbilirubinemia. So in case of BRIC and PFIC, ALP is increased, GGT is normal, and there is direct hyperbilirubinemia. So this is all about benign recurrent intrahepatic cholangitis or cholestasis and progressive familial intrahepatic cholestasis. The finally is cirrhosis. What is happening in the cirrhosis? AST, ALT will be raised, but AST will be more and ALT will be less. GGT and alkaline phosphate is quite normal, but bilirubin is increased and albumin is reduced and prothrombin time is reduced. So there is a synthetic compensation. There's a synthetic failure from the liver because everything is fibrous. The normal parenchyma is fibrous and destructed completely in the chronic ways. So there is a synthetic imbalance. Protein synthesis is going down, clotting factor is going down. So there is bilirubin increase. Which bilirubin? It will be direct hyperbilirubinemia, and there will be low albumin, prothrombin time is increased, and international normal ratio is increased, and AST is more than ALT, which is indicating cirrhosis or alcoholic liver injury. So these are the commonest pattern of altered liver function test. And other than that, there are something like anti-mitochondrial antibodies. There are anti-microsomal antibody. There are so many antibodies which are seen in autoimmune hepatitis, right? Other than that, in case of cancer, there will be alpha fetoprotein will be raised, right? So these are not usually included within the, your liver function test. But if you're suspecting something like that, then you can ask for it. So I hope within the short time, you got certain a brief view about what the liver function test and the commonest altered pattern of the liver function. So thank you so much for hearing patiently. Next. So
Dr. Rakhal, can we go for some questions?
Yeah, we can. if they have.
Okay. So, dear delegates, if you have any doubts, I think some doubts are in the beginning part. There's a case, total bilirubin alone raised in a lady of 27 years who has nausea, vomiting, and tiredness. What will be the cause? Why skin? That is the first question. Then why skin keloid in IHC? Then there are many questions. Can you tell me the first question?
Okay, I'll talk about the second thing. That is, why keloid is taken for the intrahepatic cholestasis. That is called synthesizing the rubric. This is a method called synthesizing of the rubric. You know that in case of intrahepatic cholangitis, there is a fibrosis. There is an obstruction within the small biliary canaliculi, and there is a fibrosis because of the repeated infection of these tubules, right? That is called cholangitis. Now, because of this repeated infection, you know that soon after inflammation, when they are dissolved, when it is going back, there will be fibrosis and there can be stricture. We don't have a direct rubric for that. So what we are synthesizing a remedy which can produce stricture, and especially in the liver. So how will you make it? Look for the remedy which are having an action on the liver. Look for the remedy which are having a stricture formation tendency. So stricture formation tendency, that is fibrosis. The only available rubric is skin keloid or stricture, right? Or cicatrice, generalities. Everything will be redirected to skin keloid. So when you're joining, clubbing these together, you will be getting an answer. Those remedy which can act on, which can inflame the liver and fibrose the liver, especially the tubule. So this is how we synthesize synthesize the rubric. So this is all about the synthesis of the rubric when it is not available directly in the repertoire. The first question is, there is only total bilirubin is raised, right? There is no condition called total bilirubin only raised. Total bilirubin is a combination of both. One is unconjugated and conjugated. You have to ask separately for conjugated and unconjugated. Until and unless you specify the conjugated and unconjugated, they won't give you that in the normal liver function test. They will only give total bilirubin. So ask for the separate different categories of it, that is conjugated and unconjugated bilirubin. Then only we can come to an inference. And you are saying that there is nausea and vomiting. Nausea and vomiting. So there is some problem within the gastrointestinal system, probably an inflammation. You know that acute hepatitis can come with vomiting and nausea and all those things. So if the total bilirubin is raised, you can think one cause is that the problem outside the liver, where there is unconjugated bilirubin is booming up, mainly hemolysis. There can be some autoimmune hemolysis in that lady. Other cause is that within the liver, it could be hepatitis. We have to see that. Or there are some unconjugation defect like Gilbert syndrome. Gilbert syndrome is the disease which is most often, very often getting neglected because we don't, do tests for that. It is common because whenever the patient is stressed, there is a total bilirubin rise, but there is no symptom, right? There is no pain, there is no liver enlargement, there is no other liver markers, but only bilirubin is raised, right? And if it is repeatedly doing that, then you can go for further assays, further minute or fine assay, which can detect the deficiency of the enzyme, that is ligandin, which will help in conjugation or converting the indirect bilirubin into direct bilirubin, or unconjugated bilirubin to conjugated bilirubin, that is UDP glucuronide transferase. That you have to ask separately, right? So ask for the subcategory of the total bilirubin, that is direct and indirect in that patient. And still, if it is not clear, you have to, the gold marker for this, liver function test is liver biopsy and liver scanning and MRI or CT to rule out some other, structural changes. So that's all about it. You have to go to the further categories of the liver function test. So then you will be clear, right? That's what I would like to say about it.
Okay.
Any other question, Deepu?
Yes. Yeah. I will ask only the relevant questions.
Okay.
Erythroblastosis fetalis issue in LFT mechanism, sir. I think it's a very vast topic.
Yeah, that I cannot. Erythroblastosis
No.
fetalis and hemolysis.
A case of cirrhosis when patient had stopped alcohol. How long will be the bilirubin? Will be high, and what is the life expectancy?
Oh, life expectancy. See, I mean, with the LFT, we cannot, I mean, predict the life expectancy. That we cannot, I mean, say. So when there is a cirrhosis, you know that you have to go for a USG. Other than, I mean, LFT, rely on the USG and go for a biopsy. Then it can talk about the staging. With the help of the staging, you can, I mean, what is it, talk about the, I mean, what is a age or life expectancy. The another thing is that how far the liver, the album will be reduced. You know, then cirrhosis album will be so reduced because most of the hepatic parenchyma will be converted into fibronodular regeneration tissue. So here there is no hepatocytes to produce the adequate albumin to I mean, what is maintain the oncotic pressure or the normal level of protein. So here it's all depend on, I mean, what is your treatment, what kind of treatment you are undergoing, and based on that the life expectancy will be predicted. Okay. But with the help of, I mean, liver function test, we cannot, I mean, predict anything about the life expectancy.
Patient with hematuria, patient PT increase, INR increase, patient have cirrhosis liver but LFT normal. Can you tell the reason of hematuria from this?
What are the things once again? Hematuria.
PT is prothrombin time is increased.
Prothrombin time is increased. Okay.
INR increased.
INR is increased.
Patient having cirrhosis of liver.
Okay.
But LFT is normal. Patient having hematuria. What can be the reason?
Oh, no, it already, I mean, what is it? This liver function test is what is it, altered here because prothrombin time is going high and INR is high, right? It's talking about, I mean, fundamentally about, I mean, altered liver function test, and there is cirrhosis, right? There is cirrhosis and there is hematuria. There is hematuria. What exactly the cause for that in the hematuria in case of this cirrhosis? No, with this, I mean, what is it? With the help of, I mean, cirrhosis, I cannot help, I mean, what is it? Explain the hematuria. Because hematuria and cirrhosis doesn't have any what is it, relation. Prothrombin time is increased and INR is increased. There are all the chances of bleeding, provided there is a triggering factor. For example, if there is a small calculi in the, I mean, what is it, in the kidney, it can, I mean, produce, I mean, what is a hematuria. If it is making a slight scratches, it can profusely bleed. It can bleed profusely. Or if there are some other, I mean, what is a minor abrasions, it can bleed profusely. But cirrhosis, along with the increased prothrombin time, there is a chances of bleeding if it is provoked, if there is a slightest injury. If there is without any injury, all of a sudden there won't be hematuria. Okay, so this is what I know. So I cannot, I mean, explain the hematuria in this particular case with only the pathogens. I know that there is a bleeding tendency because PT is increased and INR is increased. There is clotting is not happening properly. So if by chance any case, if there is any abrasion in the urinary tract, it can bleed profusely. Otherwise, there is no chance of, I mean, profuse hematuria in this case. Why? Because RBC cannot pass the filtering membrane. You know that in case of cirrhosis, in all these conditions, there is no problem with the lining of the glomerular filtering membrane. So RBC cannot cross that particular barrier. So there is no problem. So the problem is below the kidney, I would like to say. It is not above the kidney. Means to say, it is not in the liver, it is not somewhere else in the body. It is within the kidney. That's why there is a hematuria. I hope it is clear. And in case of cirrhosis, there is another thing which can develop later, that is hepatorenal syndrome. In hepatorenal syndrome, what will happen is that when the cirrhosis is happening, there is a lot of fibrosis. There is no space to flow the blood within the liver. So there is a portal hypertension. When there is a portal hypertension, in order to, I mean, what to say, control it, renal vascular constriction will be happening. So what will happen is that the blood which is going into the kidney will be reduced. So the kidney can go for ischemic injury. In case of ischemic injury, in that case, what will happen is that if the glomerular tuft is injured so severely, there can be hematuria. Hematuria means RBC will be present in the blood, not hematuria. Right? In other cases, there is no chance. I mean, cirrhosis causing directly hematuria. I don't know, perhaps. These are the things I know. Hepatorenal syndrome, there can be ischemic injury and RBC can start spilling in the urine. Other than that, cirrhosis won't cause directly a hematuria. But it can, I mean, cause a bleeding tendency. It can make a pavement, a platform for bleeding tendency. It can raise a bleeding tendency. So if you have small, renal calculi or ureteric calculi or vesicle calculi, it can bleed profusely. That's all I know. Yes, Dr. Deepu. Hello?
Whether there is a relation between obesity and liver function test.
Yes, in obesity, what will happen is that in obesity, there is all the chances of fatty liver. Okay, fatty liver. It is called as NASH, non-alcoholic steatohepatitis. What is it? Is non-alcoholic steatohepatitis. It is called as NASH. You know your EB NASH. It is not EB NASH, simple NASH. That is non-alcoholic steatohepatitis. So the obesity, what will happen is that there's a lot of, the liver will be burdened with a lot of cholesterol, and the cholesterol start deposited over the hepatocytes. So what will happen is that there will mimic a hepatocytic injury. There will be AST will be raised and ALT will be raised, and ALT will be comparatively more than AST. This is all about it. If it is still increasing and it is resulting in hepatomegaly, what will happen is that there will be hepatic vascular compression, and there can be ischemic injury for your liver. That is the latest stage, okay? Too much later stage. And there can be some functional disturbances if the hepatocyte is too much burdened with the deposition of the fat in case of obesity. So that is called NASH. Remember it. Okay. Yes, Dr. Deepu.
And can we donate blood with liver parameters problem?
No, you should not. You should not. You should not donate, the blood with altered liver parameters. Don't go for that. But there are something, I'll tell you that. One thing I would like to mention, there can be liver disease in the absence of normal, in the absence of altered liver function test. If the liver function test is normal and you still have problem, right? Pain in the hypochondrium, it doesn't rule out any pathology. Okay. So remember that if it is altered also, it can be normal also. So if soon after a heavy meal with, a heavy meal with a lot of fat can alter your AST and ALT level, not more than threefold. That's why I told you that when you are assessing AST and ALT, it has to be threefold increase, then only it is significant. Okay. So with the altered liver function test, don't take a chance. Don't spoil others' life. Don't advocate it. Yes, Dr. Deepu.
Can we go for 2 questions?
Yeah. Sure. If I know, I'll answer.
Okay. Chronic carriers in hepatitis B. Chronic carriers in hepatitis B.
Hepatitis B, yes.
What is the investigation criteria in prognosis and life expectancy?
Very good. That is a good question. Actually, I didn't discuss it because it is out of our preview. I need more time to explain, again, liver function test, because I was so conscious about the time, and I was little disoriented when I was
if you are free for one more session, people are asking. We have around 370 participants, and they are keep on asking about another session.
Okay,
if you get time,
we can do. Yeah. Hepatitis B. I'll tell you that this is a virus, which is a DNA virus. That is the most important thing. You know that virus is a smallest microparticle, just bigger than a prion, because the smallest infective particle is prion. Above that is a virus, and the virus is having a genetic material inside, and it is encircled by a protein coat. So the viruses are classified into RNA virus and DNA virus according to the genetic content within it. So hepatitis B is a DNA virus. So what is happening is that the DNA virus is having very similar to your hepatitis, can be easily become the part and parcel of the body, and you become a carrier. You will go to a carrier state of hepatitis B. Now, how to predict the life expectancy in case of hepatitis B? This is a very good question. You know, hepatitis B is having so many antigens. There is a surface antigen, there is an envelope antigen, there is a core antigen. Now, whenever hepatitis B is the carrier state, check for something called HBeAg, HBe, envelope antigen, E for HBe antigen. So whenever there is a HBe antigen is very raised in a hepatitis B carrier, it talks about a severe acute inflammation, ongoing active pathogenesis done by this particular virus. So when HBe antigen is present, check for it. If it is too much high in hepatitis B carriers, the patient's life is in the risk, one thing. The second thing is that he is very, very infective. Okay, so in a hepatitis B carrier state, check for HBe antigen. If it is positive, significantly high, the patient's life expectancy is very low, right? And he is infective also, right? We have so many parameters to discuss about it, about life expectancy. If you're a good, healthy person, hepatitis B can't do anything for you. But as you grow old, as your liver is wearing out because of your eating so many toxic particles, you know that toxic particle is a part and parcel of your food, daily food. We cannot avoid it. So because of that, what will happen is that there will be constant injury. As you're growing old, what will happen is that if you are a hepatitis B carrier, it can slowly get converted into hepatocellular carcinoma. But the chances in hepatitis B for developing hepatocellular carcinoma is less compared to hepatitis C. That is a notorious virus to cause hepatocellular carcinoma. The maximum danger is with hepatitis C virus, but hepatitis B virus also can go to cirrhosis and later hepatocellular carcinoma if your liver health is reduced. So if you go with the routine, nothing will happen for you. So that's it. Yes, Dr.
Okay, so I think it's 4:30. We are concluding our session. We have so many questions. So I would request something to the participants. Please subscribe our channel and join our Telegram group where you can get all the upcoming programs and details. And Dr. Rakhal will be ready to take further sessions. We will discuss and we will come up with later. So on behalf of IHMA Kerala, I express a very sincere thanks for Suraj. Dr. Suraj, also a part of IHMA, who has been holding this iPad for so many times. Dr. Suraj too, a very big thanks. And Dr. Suraj's ECU session is on coming, and there are so many good messages are coming. And Dr. Rakhal is not having any WhatsApp, so I will send him through mail. I will send all these things. And thank you so much for a fantastic session. And thank you.
Okay. Thank you so much, Deepu. And thank you so much for the participants for patiently listening to me all these hours. Thank you so much.
Thank you. Okay.